Okay, welcome everyone. Tonight in Henry School, I'm Dr. Dan Henry from Hotel Panel Clinic. We're going to be talking about a bit of an overview of headache treatment, and a lot about the new treatments that have come out, and most importantly, how do you ultimately to get somebody as a patient to get some of these treatments. And so, first of all, I wanted to read a quote that I just saw the other day from Dr. Richard Lipton, who's a famous researcher in headache medicine. And it shocked me on the one hand, and on the other hand, it's what we see every day. And he said that they had just finished a study when they were looking at patients with chronic migraine, and they found that only 1 out of 20 were accurately diagnosed, and given a minimally effective guideline recommended treatment by their doctor. What that means is what that means is as he went on in his letter and in his summary was simply that we have a long way to go to identify all the migraine patients out there. When you consider there's roughly 36 to 40 million migraineurs in the United States, and there are less than 1,000 headache specialists in the United States. Those odds and your odds, if you're of finding a migraine sufferer, of finding a doctor is pretty tough, and it may take a long time, and that's what a lot of patients find is they go years without getting adequate treatment. And so we're going to try to clarify a little bit of that tonight. So first of all, making the correct diagnosis. Treatment plan really simple. I look at it in 3 real areas, and that is number 1, lifestyle. In other words, what is the patient doing at the time, and what can you do to help them to take pressure off of their headache disease. So when we talk about lifestyle in other lectures, and I know you've heard this in other lectures, is number 1, first of all, when we talk about lifestyle. So first of all, when we talk about lifestyle, first thing I always approach is how someone's sleeping. Because if you don't get adequate sleep, it's very difficult to get headaches under good control. And if you find somebody who has chronic migraine and they have 15 to 30 headache days a month, and they're having migraines at least 8 days a month, and they tell you they sleep beautifully, something doesn't fit because it never happens. So number 1, exercise. Number 2, and exercise studies showing, and there's good studies showing that if you exercise mild to moderately 30 days a month for 30 days a month for 3 months, you'll cut your headaches in half. If you with the caveat being that if you over-exercise, it may trigger a migraine. So it's moderation and finding that balance. And thirdly is diet. And I know we've had whole programs on diet, and I'll just summarize a couple of things. Key points is ideally you want your patients eating as clean a diet as possible, and frequent small meals much better than skipping meals, and fasting is a real no-no for the majority of migraine sufferers. So that's really lifestyle in a nutshell. Secondly, we talk about rescue. And in rescue medication, when we talk about rescue, we're really talking about what do you take when you feel a migraine coming on. And we start, oftentimes, some people will start with non-steroidals. There are a lot of different medications. Triptans are the mainstay as migraine-specific medication. And then making sure that the patients aren't overusing or medication overuse headaches, and we've had entire discussions about that as well. So that's really acute. Then we get down to the nutshell of prevention. So if you have, first of all, once you've made the diagnosis, and you've made the diagnosis of migraine, and then you're talking about frequency and severity, there's that point where you decide, does this patient need preventatives, i.e. something to do that they take medication-wise on a daily basis, or do they just need the rescue medication? And there's most people kind of a uniform consensus that somewhere between 4 and 6 migraine days a month is enough to consider someone for prevention. And this is a discussion to have with your doctor, and you know, it's something that you decide together. Now, 4 to 6 days a month, for some people, if their migraines are very, very severe, let's say they're only having 2 migraines a month, but each of those migraines, they either miss school every time for an entire day, or they miss work for an entire day, or that 2 migraines is actually 2 migraines, but each one lasts 2 or 3 days, and they're missing even longer periods of time. For those individuals, you'll start them on prevention right immediately, oftentimes. So when we talk about prevention, and this gets down to what the real subject of tonight is, which is the new treatments. We talk about prevention. We talk about, first of all, traditional prevention has been 3 major classes, and I'm talking also from the point of what do you have to do with your insurance company to get different treatments. And so most insurance companies require you first to go through the 3 major classes of anti-seizure medications, with medications such as Topamax, Depakote, the tricyclic antidepressant class of medications, amitriptyline, nortriptyline are the 2 probably major ones used in headache, and then beta blockers, with the key one being propranolol, metoprolol, and a few others. And then there's other classes that are used, but from an insurance standpoint, those are the 3 classes that are key. And that means key that if you take these classes and you're still, say, and we're talking predominantly with either high frequency episodic or indeed chronic migraineurs, 15 to 30 days, then that individual qualifies, according to most of the insurance companies, as eligible for Botox. And so when you start pre-authorizations, you can usually, if you go through all the classes, and when you say go through them, it means that they've taken them for an adequate period of time, which for insurance companies means about 3 months, in fact, typically 3 months, or they didn't tolerate them at all. They had side effects that didn't allow them to take them for 3 months, but they still tried them and they couldn't go on. Then that's still, you can still put a check by that class of drug when you're putting in pre-authorizations for more advanced treatments. Now, if the individual also, with some of our insurances, if they also have tried between 2 and 4 rounds of Botox, these are given at 12-week intervals, if they've actually had 2 to 4 rounds and they're still not getting at least a 50% reduction in their headache frequency and severity, then they now can go on to the monoclonal antibodies against CGRP. And I'm going to cheat a little bit instead of talking about each one individually, because basically there are 4 and that are coming out. Right now there are 3, with the 3rd one just getting onto the marketplace. And when you look at the data of these 3 medications, and the 4th one will probably be out sometime in the first part of next year, if it gets approved, which it probably will. Then you look at those, that class, and that is a whole new class. I mean, this is the most, in my mind, one of the most exciting things, if not the most exciting thing in migraine prevention in the last 20, 25 years. This is the first class in recent decades that was actually developed for migraine and for headache disorder. I mean, if you look at all the previous classes that we talked about, including Botox, they were all developed for other diseases, and they were found to, gee, they happen to reduce migraines. So now we have a class of drug, the monoclonal antibodies against CGRP, that were actually developed for a very specific target. And CGRP is a neuropeptide in the brain, produced and secreted by the neurons. And in migraines, in migraineurs, the levels are much higher in a majority of migraine patients. And this class of drug either works by binding to the receptor in one class, here in one case, or binding to the ligand itself in the other 3 drugs. But interestingly enough, at last year's national meeting in Scottsdale, David Dodick was talking about these, saying that when you looked at all 4, and he'd looked extensively at them, that it looked almost like the same drug. The response rates, the side effect profiles were nearly identical. And I know we'll all find different people who say this one may be better than that one, etc. But we don't know at this point. They all appear to be very, very closely matched. And that's great, because it adds competition too in the pharmaceutical industry. And so that's hopefully good for all the patients that may benefit. Now, one issue, and the reason I'm really bringing this topic, decided to talk about this tonight, is that a lot of patients have been seeing things online, seeing things in the news, and they're calling. I got a call today from a patient in Canada, up in Alberta, and they wanted to get one of our drug, one of the monoclonal antibodies for CGRP. And I was talking to him briefly and talking about what had they been on. They had never been on a preventative. They'd never seen a headache doctor. They had just read online on one of the websites that this was the drug they should be on. And the bottom line is, a lot of people are kind of confused, disappointed if they can't get immediately to it. Now, some of the monoclonal antibodies, some of the pharmaceutical companies are in fact, all of them are being very, very generous right now in giving free doses to start out, using either hubs or directly local pharmacies, etc. And they aren't being as strict as the insurance industry. So the one issue I have is some of them are only requiring that, yes, you would qualify in the sense of the number of headaches, but maybe you only have to have failed 1 preventative previously, or 2 preventatives. And that may be well and good, and they have an extension where you can get the drug for free if you don't qualify with your insurance company for even up to a year. I mean, that's tremendous benefit, because we're talking about medications that are injected once a month or once every 3 months, and the price is running around $575 a month if you were trying to pay for it with cash yourself. Now, my only concern with that is if somebody's only had one oral preventative and they go on one of these medications, and even if they get a great response, their insurance companies right now won't even consider allowing them to stay on. They're all denied. So clinic staffs, etc., spend a lot of time filling out pre-auths and getting denied. And so I guess one point I'm trying to make to patients is go through the steps, go through the criteria, go through the 3 classes of oral preventative, and some require Botox before going to the monoclonal antibodies, others don't. So we have one major insurer in our region right now that you can go to either monoclonal antibodies first or Botox first. And personally, I would probably go to the monoclonal antibodies first, because oftentimes we get a response very quickly. And since you're giving these injections once a month, by 6 months for sure you're going to know if somebody's a major responder or not. Okay? A little bit about, and by the way, I want this to be very open. If anybody has questions, feel free to pipe in and raise your hand or just speak up, because I want this to be very casual tonight, okay? But I'll keep going until somebody does. So first off, looking at the results of a number of the studies out there, it appears that about somewhere between 12 and 15% of patients with this class of drug are what we call super responders. And super responders are patients that literally you give them one dose, and within 2 weeks, their headaches, even if they're at 25 or 30 migraine days a month, they go to 0. And we're out over a year now with continuous dosing once a month with a number of these patients, and they stay at 0 as long as they're getting their dose every month. So I mean, this is life-changing medication for these patients, okay? Because remember, with chronic migraine, about 2/3 of the patients cannot go to school full-time if they're students. They cannot work full-time. A lot of them are on disability. A lot of the kids are on home and hospital. This is a devastating disease that's underappreciated. You know, this is a serious neurological disorder that is one of the top 10 causes of disability in the country and in the world. And it gets very little recognition, okay? And I know I digress for a second. Anyway, so that's roughly 12 to 15% of the patients who are these super responders. And that's, you know, you won the lottery. If you're not that group, there's about 10% that don't appear to respond to the monoclonal antibodies. They don't get a response at all, or minuscule, and definitely less than 50% reduction, even after multiple doses. So that leaves this large chunk in the middle of about 75% of the people. And of those individuals, they tend to gradually get better and better and better, and some of them much faster than others, but a very high percentage after 5 rounds or 5 months of treatment have at least a 50% reduction in their migraines, And a fair number are actually at 90% reduction. Again, that's life-changing for these individuals. That's giving them their lives back, their work life, their social life, their family life. I mean, this is a really big deal. And then you come to side effects. You know, the oral medications we talked about, you know, that were all developed for other diseases, well, guess what? I kind of look at it, if your migraine disease was a silver dollar on the wall, a lot of our previous treatments were kind of like shooting at it with a shotgun. And so if you're lucky, it hits it, but it also hits a lot of other things, and that's the side effects. You know, whether that's brain fog, whether that's paresthesias, whether that's hypotension and dizziness. I mean, the list goes on, constipation, on and on. With the monoclonal antibodies against CGRP, the side effect profile so far, and we don't have data beyond, I think the first study we were involved in, one of the first phase 2 studies, it was about 5 years ago. And so that's about as long as we have data, and most of the longer term studies are still under 2 years. They're about 18 months or so. And so, but at this point, this is an amazingly clean drug. I look at it as it's shooting at that same silver dollar on the wall with a laser beam, because it doesn't hit a lot of other things. Most common side effect with it is a local reaction, itching, or burning a little bit at the injection site. A few people after multiple doses have had allergic reactions to it. Most of them been very mild. Most of them have been rashes again or itching. And a few people have had a little bit of constipation. And that's about it. Don't see many classes of drugs coming out with that kind of a clean profile. Questions?
So people who develop the allergic reaction, do you have to take them off of it, or can you like give them Benadryl?
That is a very, very good question. And I don't, it depends on how. Oh, yes. The question was, if someone has an allergic reaction to the monoclonal antibodies as itching or rash, and it's fairly mild, you have to stop the medication. And right now we don't have all the answers. We don't know if you can go on. I happen to have some patients that are very desperate that have had great responses. And what we're doing is actually having them taking antihistamines for 3 or 4 days before and 3 or 4 days after, and so far they've had, the reaction has totally dissipated. So they haven't had any continuing. Obviously, if you had somebody who had bronchospasm or laryngospasm or more serious type of allergic reaction, anaphylaxis, obviously you'd have to take them off. But I think for minor reactions, we'll hopefully know the answer. I can answer that in a few months or years. But right now, I have some patients who it's turned their life around, so they're going to take the chance. Yes?
I have a question about the refrigeration of it and when to get it out before taking it. You know, because I started reading that, because I'm one of your patients that just started.
Yes. Okay. The issue of refrigeration. So if you have it for longer term storage, you want to refrigerate it, not freeze it, but just have it in the refrigerator, and you want to keep it refrigerated. Now, a number of them can be left out for up to 7 days. I wouldn't do that typically, because 7 can turn into 8 or 10, and so I would keep it in the refrigerator till the day of. The day you're going to inject, the current recommendation is to leave it on the counter for about 30 minutes. The only reason that I've been able to find, and maybe anybody else can tell me something that they've heard further, but the only reason to leave it out for 30 minutes is slightly less injection discomfort. And to tell you the truth, most patients, if we've given samples in the office, etc., we want to demonstrate giving the injections. They don't want to wait. We give it cold. I haven't had anybody complaining at all about giving it directly out of the refrigerator. So if you want to leave it on the counter, I had one patient who said, you know, I tried it both ways. And they didn't notice any significant difference. So I don't think it's really a big issue. It is in the company flyers for 30 minutes on the counter. Any other questions? This is a life-saving class of drug. You know, again, it's not the end-all, be-all. It's not the final chapter by any means. It's not a cure. But it is a huge new weapon for a significant number of patients who, up to this point, maybe have never had anything that they've responded even adequately well to. So I'm very excited about this class. I am interested to see how things play out with the insurance companies, because I hate to say it, we're all in that. We have to be able to learn this game. I do think it'll help us if we do all the steps to get to the monoclonal antibodies. I think you'll have many fewer problems getting this drug for your patients long term, and that's where I'm kind of looking at. I don't see this as a one-day treatment or a 1 year. This is for some of these individuals who do well. Hopefully this is, life-changing, lifetime type of drug. Yes?
One more question. Not every pharmacy is carrying this.
Correct.
And I requested my pharmacy to look into carrying it, but they said their wholesaler doesn't have it. Is it hard for pharmacies to obtain? What's limiting more pharmacies having it?
I think that's going to be answered very shortly, and I think more and more pharmacies are carrying it. There are a number that are very easy to get it. I can't really do commercial endorsements here, but there are a number. If you call your physician's offices, they can tell you which pharmacies that have it on hand all the time.
Okay. The pharmacy that I went to, my insurance doesn't work with that pharmacy, so I was just wondering if things might...
Right, there are a number of them now, and it seems like the numbers are increasing pretty much almost on a weekly basis right now. The very first drug that came out in this class, just to give you an example, their hub for their free samples that had to come from a central distribution center and was mailed first to the doctor's office and then to the patients. That hub, when that product got approved, they expected around 2,000 requests a week. They were receiving greater than 10,000 requests a week. So the demand is there. When we talk about this disease, and I can't state it enough, this is a migraine disease is a stigmatized disease. People, even family members, employers, employees, people think it's just a headache. And it's not. It's a serious, severe neurological disorder, and it impacts so many individuals, so many families, and yet it's kind of in the shadows. It gets very little NIH funding. You know, I'll give you a good example there. Within the last 3 years, the amount of NIH funding for diabetes was about $1.1 billion. The NIH funding for asthma was over $400 million. The NIH funding for headache disorder and migraine disease was $27 million. And there are more migraineurs in this country and in the world than there are diabetics, type 1, type 2 combined, and asthmatics combined. So we need to get more people out there trained to take care of migraine patients. We need the word to get out. We need education to get out. Any other questions?
Is there any data about these new medications in pregnancy?
About this class of drug in pregnancy? The monoclonal antibodies, we try, you know, of all preventatives, we try to get women off of preventative medication if at all possible. And probably the safest treatment in pregnancy by far is for prevention and for rescue in severe cases where they're having multiple migraines day after day, are nerve blocks, trigeminal nerve blocks, greater occipital nerve blocks, and these have been shown to be safe in all 3 trimesters, also in nursing mothers, and with no suggestion of any type of teratogenicity or maternal issues. As far as the monoclonal antibodies against CGRP, they're recommending at this time at least 5 half-lives. So we're talking about from the last dose, if a woman, because let's face it, you know, we're talking about a disease that affects 18% of women, 6% of men. The peak years for women is in their childbearing years. So we're talking about something that happens all the time. And so from a safety standpoint at this point, we're saying at least 5 months from your last dose of monoclonal antibody. And while I'm telling my patients that are of childbearing age that they shouldn't go on unless they're on birth control, and stay on birth control until 5 months after the last dose. Any other questions? In that case, I think we're done. A little early, but done.